So we are going to talk about stenting as rescue therapy. So we are going to start talking about failure, how we fail during mechanical thrombectomy, and the options that we have after that failing to try to at least leave the vessel open and try to improve the prognosis of our patients. So this is the summary that I will going to follow. First of all, we need to define the problem, and then we need to ask about the solution that we have, when and how implement this solution, and the 0 to G0. That's the study that we are doing in Spain and Portugal regarding the need of stent placement after a failure in mechanical thrombectomy. And at the end, I will talk about our results in our hospital with this new protocol. So the problem is that we need to assume that we are not able to open all the vessels. And this is important, okay? Because right now we are getting really, really good results. Of course, we have TQ2B3 greater than 90%. Even though right now we are talking about TQ2C3 to try to improve our results a little bit more. But we are going to have between a 5 or a 10% of patients where we are not able to remove the clots, okay? And I'm going to talk about all those patients. Of course, in this group of patients, we have patients with intracranial stenosis and patients with a resistant clot. Most of the time in Spain, they will be resistant clots. Maybe in your population, it will be due to intracranial stenosis. But at the end of the procedure, we have the same problem. The vessel is not open. So we need to give something different to that patient, some different treatment to try to open that vessel. These are all our results related to the procedural result that we have. So if you have a TQ2C3, as you can see here, this is the probability of a good clinical outcome, a ranking between 0 and 2. This is the probability of ranking 3, ranking 4 and 5, and ranking 6. And as you can see, when we get this TQ2C or 3, we have this much independent or neurological independent patients, 60%, while the mortality descends to less than 10%. While on the other side, patients without a good removal of the clot, and I'm talking about TQ0 to 2A, the probability of ranking 0-2, it's less than 15% with a big increase in mortality. And the thing that is worst in this situation, that's ranking 4 and 5. So we know that it's really important to open the vessel because that's the main variable that will change the prognosis of our patients. So how many passes should we do? When should we stop will be the question that we need to answer, sorry. So we know that those vessels should be open. The better the opening that we have, the better the result. How many passes? There are lots of papers, as you can see, these are only 4 of them, where they establish the number of passes and the probability of getting a good clinical outcome after each one of those passes. And this graphic, I think it's the most important thing to understand how we work. So after the first pass, as you can see, close to 60% of the patients will be neurologically independent. When this number of passes advance and grow, the probability of getting a good clinical outcome decreases a lot, okay? So here you can see how this number of passes that we have in this situation, and the second pass, the probability of that clinical outcome goes a little bit down. And when we reach the 5th pass, it's really anecdotal to have a good clinical outcome. Of course, after 6 or more passes, it's only 1 patient in all this population. So these people established that number, the 5th pass, as a frontier of futile recanalization. So after that 5th pass, it is not useful to open the vessel. Only sometimes it will be useful. So the problem is really fixed right now. We can't open all the vessels. even after several passes. And we know that after 4 passes, recanalization becomes improbable and futile. So it's really rare to open the vessel after the 4th pass. We will talk about this a little bit later. And the recanalization is not going to be useful, even though we get to remove completely the clot. With this concept, right now, there are some papers that they have changed this view, and they keep saying that if you are able to completely remove all the clot, even after 5 or 6 passes, you can have this good clinical outcome. But as the probability of recanalization decreases, this effect is not that well measured. So when to do this? Well, this is based on the first close to 700 patients that we have in our hospital, all the ages, all the rankings, everything. And this is the probability of good clinical outcome after each one of those passes. And you can see how this graphic is a line that goes down pretty much the same as what we have seen on the publication that I did show you. After 1 pass, 60%, and then after the 4 pass, it gets to 35%. This is a strange thing, but because we don't have that many 5 passes, we on this graphic we have this result that it maybe should be a little bit lower, so the graphic will be a perfect line. I can imagine that right now with more than 1,000 patients, that graphic will be pretty much flatter. And this is what I want to show you, that after that 4 pass, this recanalization tends to be a little bit futile. And also we know that after those 4 passes, or even after the 3rd pass, the probability of an hemorrhagic event to appear will increase dramatically. So right now, if you think, we have a technique that after the 4 pass, it's going to be not that useful. It's going to be really hard to remove the clot, and we are having more complications. So maybe mechanical thrombectomy after 3 or 4 passes is not the best technique to treat patients with a stroke and with a large vessel occlusion. This is a study that we performed in Madrid with between 3 hospitals, and we studied the probability of recanalization after each one of our passes. So this is the accumulated percentage of vessels open. So with the first pass, we were able to open 40% of the vessels. With the second pass, that percentage increases to 60%. You can see these numbers on this graphic that will make even easier. So as you can see, we have 2 frontiers. Oh, there's no graphic. I don't know what happened. Sorry. So only to show you, this 60% goes to 75% after the 3rd pass, and it gets to 80% with the 4th pass. After that 4th pass, as you can see, the accumulated probability of recanalization is really, really low. With the 6, you get to 84, and then it flattens after the 11th pass, where we were able to remove 1 clot. So after 4 pass, that curve gets really flattened, and after the 6th pass, there is no benefit or no good probability of recanalization. This is the probability of recanalization in each one of those passes. So with the 5th pass, we were able to open 16% of the vessels. With the 6th, 4%, 7, 4%. And then, as you can see, there is 1 patient with these 11 passes. We all know this patient, normally a young patient that is suffering an important stroke on the left MCA or whatever. So we try to remove the clot as hard as we can. But the thing is that we need to understand that this technique, the mechanical thrombectomy, that has really good results on the first 3 passes, it is really bad after the 4th pass. And as you can see, it's really improbable that we are able to remove the clot after the 5th, the 6th, or so on and so forth. So how can we treat these patients? And that's what we do right now in our hospital. We need to change the technique. It's not that useful anymore. There are lots of papers that publish the need or the utility of the stent placement in mechanical thrombectomy as a rescue as a rescue therapy, but we have two main options, the angioplasty and the stenting. Of course, both of them have some bad side. The angioplasty, we are going to have one big problem, is that we don't know the vessel size. And of course, we don't know the clot or the stenosis strength. So if you add those two concepts, you are going to inflate a balloon that's going to try to break the clot or break the stenosis, but you don't actually know the actual size of the artery, and you don't know the strength of the clot. So maybe you are not going to break the clot. Maybe you are only going to push the clot against the wall, and that increases the risk of intracranial bleeding due to the breakage of the MCA. So we have to be really, really soft with that angioplasty, but we need a big angioplasty. So it's a big dilemma. While with the stent problem is that most of the stents, they have low radial force, so they are not able to open all the stenosis by themselves. We were used to those stents where we needed to perform this microcatheter exchange after the angioplasty to perform the stenting. And of course, there is the need of antiaggregation in these patients. If you want to place a stent, the patient should be under a double antiaggregation to keep the vessel open. That's one of our main objectives in this group of patients. So if we talk about the stent, this is the study that we perform in our center, and it's published there. You have the reference, where we analyze the first 500 patients, the ones that we weren't able to open the vessel, the TK0 and 1, those were 60 patients, and we have 20 of them with rescue stenting and 40 of them without stent. So these were the results. And this is really important for you to see how after mechanical thrombectomy success, we were able to get close to 50% of ranking 0 to 2. If that mechanical thrombectomy fails and we needed to place a stent, the probability of good clinical outcome was close to 45%. So this was really amazing. And patients without stent, this probability decreases to 2.5%. So of course, this study was suffering all the bias that you can imagine, because we were selecting the patients that will have better prognosis based on our opinion. So it's the problem with all the retrospective analysis, okay? But we see that placing stent was not that crazy thing to do on those times, okay? Their results were not that bad. We were not having an increase in mortality. We were having a good clinical outcome. So it has a lot of sense to try to perform this kind of more aggressive treatments or more aggressive approaches. Of course, there are a lot of papers like ours in the literature. You can see here, this is a retrospective analysis, good clinical outcome, of course, 45%. This is another one, retrospective, 40%. This one, it's really important because it's using the technology that we are using right now. They were using a Clino and Neurospeed. Neurospeed is a balloon designed by a Candice that it's really important because it's able to navigate inside the intracranial circulation. It can perform a high pressure angioplasty, and through that microcatheter that has 2 lumens, we can place a stent. We can place a Clino and Credo stents, both of them, to treat this kind of problem. So this paper was really important because it was proving the effectiveness and utility and safety of this technique. Another one, this is a systematic review and meta-analysis with retrospective trials, and all of them, they were close to 48% of a good clinical outcome. So our method that we have changed during the last 4 or 5 years is that right now we have a limit of 4 passes. This method, it's inside a protocol that we call 0TK0. We have a limit of 4 passes, so we don't perform more than 4 passes never. After those 4 passes, we make a CT on the angio room to rule out any kind of hemorrhagic problems. Then we apply the tirofiban or the AT2B3A antiaggregation, so intravenous antiaggregant that goes really, really fast and blocks almost all the platelets in less than 10 minutes. Then we perform the angioplasty with the NeuroSpeed, and after that we place the Credo. The Credo is the there are only two stents that have the IFU to treat intracranial stenosis: the Wingspan and the Credo. The Wingspan has the problem that it's really complicated to perform the release after the angioplasty, because you have to make an exchange, while the Credo is really straightforward after the angioplasty with NeuroSpeed. There we have the combination of a NeuroSpeed and a Credo that's being deployed through that catheter balloon or microcatheter balloon. So this is how we work. We take the decision that we need to treat the patient. We put that patient under tiotropium with a bolus and a perfusion, and we keep the patient with a perfusion for the first 12 hours. After those 12 hours, we perform a CT and an angio-CT, CT to rule out any kind of hemorrhagic complications, an angio-CT to prove that the vessel is open and the stent is open. And if we are able to prove that, we stop tiotropium and we change to aspirin and clopidogrel with that amount at the first time, so 500 milligrams of aspirin and 5 platelets of Plavix. And we keep the patient under double antiaggregation for the first 3 months with a standard dose of treatment. And then after those 3 months, we keep the patient with aspirin for the rest of its life. So as you can see, the only thing that changes is that we add clopidogrel for the first 3 months, and we add tiotropium for the first 12 hours. The rest is pretty much the same, and we treat the patient with aspirin like any other stroke patient or stroke treatment or secondary prevention of this stroke problem. And these are the results that we have applying this protocol. And I need to say you that this protocol, it's prospective, it's not retrospective, and we have placed the stent in all the patients with a failure in mechanical thrombectomy. So this is not selected cases, these are consecutive cases. Independently of aspects of TPA or whatever, we place a stent to try to study the benefits of this technique. So this is the 36 patients that we have. 76% they had hypertension. Important for you to know that we have 3 patients with higher ranking than 2. Well, because we are doing a prospective series, so we have not selected the patients. And if the patient have a ranking 3 due to a polyarthrosis or whatever, we treated it. Okay. The only thing that does not allow to treat patients, and not because of the stent, but also for mechanical thrombectomy, is that we have a neurological ranking greater than 3. Okay. If not, all the patients go inside the angio room, and if they go inside the angio room, they are candidates to stent rescue if it's needed. On this prospective series, we have only a 25%. We have 25% of the population that they were previously antiaggregated, maybe because those previous ischemic strokes, or maybe because of another problems in the heart, coronary arteries, or this peripheral vessel occlusion, or whatever you can imagine, they were under antiaggregation. The strokes were, well, NIH of 17, not that big, but it was an important clinical strokes, all of them. TPA only in 30% of the cases. Normally in our population is close to 60%, but with this series, as I have told you, this is consecutive. So time was not a problem for us to place the stent. And sometimes because of the time, patients were not candidate to TPA. The aspects was 9. These were the times to onset to recanalization, and the procedural time that was close to 2 hours. If you can imagine, 4 passes, the CT, tiotropium, so on and so forth. So it's close to 2 hours. These are the results that we have. Most of the patients were with M1 segment occlusion, some of them with terminal internal carotid artery, 1 with a vascular, and we have 6 patients with an M2 segment that we treat with these techniques. The recanalization rate, as you can see, is not perfect, but it's not that bad. It's much better than what we have on the 5th pass. So if you remember, on the 5th pass, we have a recanalization success of 16%, but with this technique, it grows to 77%. So close to 80% of the patients keep the vessel open after or have a recanalization rate greater than 2b3 in 17% of the patients. This is the rescue technique that we apply. So only stent 44 patients. That's pretty much the same as the one with angioplasty plus stent. Those two groups are 16 patients in each group. So that give us to 32 patients, and the rest, the 4 other patients, they were treated only with angioplasty, because we were trying to establish the utility of this technique. These are the complication rates, not only of the procedure, but on the first 24 hours or first week. We have 3 symptomatic intracranial hemorrhage. One of them was due to a procedure complication. So at the end, it's only 2 related to the evolution of the stroke, and 0 delayed hemorrhage. The mortality, it's 21%. Don't forget, we are treating consecutive patients, not the nice patient, but all of them, and the mortality was well, a little bit high, but not as high as the mortality if we leave the vessel closed. Don't forget about this concept. And this is the stent parency at 12 hours control. 80% of the vessels were open, but if you can see the ones that they were closed, we have each complication. One of the occluded vessels was due to the complication, so we occluded it by ourselves, and the other 6 occluded or thrombosed stents were 2 in each branch of our treatment. But as you can see, the angioplasty alone had a 50% of occlusion at 12 hours, while the stent, or both angioplasty plus stent, was close to only 10% of the cases. So as you can see, leaving stent appears to be the best thing to do if you want to assure that the vessel will still be open at 12 hours. And these were the results that we have at these charts and at 90 days. As you can see, the ranking 0 to 2 is not that perfect as in the retrospective study. So while we used to have a 45% rate, now we have a 38% of neurological independent patients, but we are not comparing with discharge MRS. No, we don't forget, we are comparing against ranking TK0 patients. So patients that will leave the vessel closed after a mechanical thrombectomy procedure, and the probability of a good outcome in those patients were really low, close to 2.5%. So when to treat? Well, we decided that after the 4th pass, we were going to place the stent. And as you can see, we match the probability of good clinical outcome after that 4th pass. That makes me think that maybe if we perform this kind of rescue treatment after the 3rd pass, the probability will increase. But that's what we need to study, and that's what we are doing right now, to trying to study if after the 2nd pass, placing the stent is the thing to do, or maybe we have to wait until the 4th pass. So this is how we think and how we work right now. So we cannot remove all the clots. Don't forget about that. A stent placement can be an option. Its safety and its efficacy, and investigations are ongoing to prove its efficacy in a prospective trial. That's what we are doing in 0TK0. Lots of centers, lots of population trying to define the prospective value of this technique. So thank you very much, and it's a pleasure to be part of this meeting.